Welcome to the deep dive. We've got the American Heart Association's basic life support info here. And our mission today, it's really to break this down so you feel genuinely prepared, not just like you read a manual. We want to give you the core things you need for those critical moments.
Absolutely. And, we have to start with something absolutely fundamental, something people mix up all the time. Heart attack versus cardiac arrest. They sound similar, but they're completely different things happening in the body.
Right. That feels like the bedrock here. If we don't get that straight, nothing else quite makes sense. So heart attack, what's the core problem there?
Think of a heart attack as a plumbing issue. It's a clot problem. Essentially, blood flow gets blocked off to a part of the heart muscle itself, like a clogged pipe, really.
Okay, a blockage. But the heart itself is often still trying to pump.
Exactly. That's key. The heart is usually still beating, still pumping blood, but it's struggling, and the muscle's getting damaged the longer that blockage stays there.
And the signs reflect that. Chest pain, feeling winded, maybe sweaty, nauseous. But the person's generally awake, they can talk to you.
Usually, yes. Now flip that completely for cardiac arrest, CA. This isn't plumbing, it's electrical. A rhythm problem. The heart's electrical system goes haywire, it develops this abnormal rhythm, and it just stops pumping blood effectively, like the engine just seizes instantly.
Wow. Okay, so the signs there are going to be much more dramatic, much more sudden.
Stark is the word. The person collapses, they're unresponsive, they're not breathing normally, maybe just these occasional gasps, which isn't real breathing. And critically, no pulse, zero blood flow. That needs action now.
Okay, so that leads us right into the response. If CA is the sudden electrical shutdown, we need a plan. The sources talk about these chains of survival, and the urgency really hits home when you realize where most of these happen.
Yeah, the stats are pretty sobering. Most out-of-hospital cardiac arrests, or OHCAs, they happen right in the home.
Which means that the first person there usually isn't a paramedic. It's, family, a friend, you.
Exactly, which is why that out-of-hospital chain of survival is so crucial. It starts the second someone recognizes what's happening. First link. Call for help immediately. Activate that emergency response system, 911 or whatever your local number is.
Get the professionals moving.
Right.
Yeah.
Second, start CPR right away and really focus on those chest compressions. Push hard, push fast.
Because until help arrives with, the defibrillator, you are the heart, essentially. You're manually pumping that blood.
You're buying critical time for the brain and organs, which leads perfectly to link number 3. Get an AED on them as fast as possible. Rapid defibrillation.
That's the machine that can fix the rhythm problem.
That's the fix. Then comes advanced life support from the professionals, and finally, that specialized post-cardiac arrest care in the hospital. But, a really important point for bystanders, even if you've never taken a CPR class, the recommendation is clear. If someone collapses, isn't responsive, isn't breathing normally, at least push hard and fast on the center of the chest. Doing something is way better than doing nothing. Don't let fear stop you.
That's huge. Just start compressions. And the goal for all of this, the medical term, is ROSC, return of spontaneous circulation.
That's the immediate goal, yes.
Yeah.
Get the heart beating on its own again. And the single most effective way to achieve ROSC in many adult CAs.
It's got to be the defibrillation, right? Fixing that electrical chaos.
Exactly. Step 3, defibrillation. Compressions keep things viable, but the shock is what often restarts the normal rhythm.
Okay, let's get practical. An adult collapses, first thing. Always.
Always. Scene safety. Make sure you're not running into danger yourself. Live wires, traffic, whatever. Check the scene first.
Right. Scene safe. Then what?
Check if they're responsive. Shout their name. Tap your shoulder firmly. Are you okay? Are you okay? If no response, immediately yell for help. Point at someone if you can. You. Call 911. Get an AED if there's one nearby.
Activate the system. Get the gear coming. Then you check.
Breathing and pulse. Look, listen, and feel for breathing. Check the carotid pulse. That's on the side of the neck. And here's a really critical time constraint from the guidelines. You check for breathing and pulse together for at least 5 seconds, but crucially, no more than 10 seconds.
10 seconds max. Why so strict?
Because time is brain. Every second without blood flow means potential brain damage. If you spend 30 seconds feeling around, unsure if there's a pulse, that's 30 seconds too long. If you can't feel a definite pulse within 10 seconds, you act as if there isn't one.
Got it. Assume no pulse and go.
Yeah.
So let's game this out. You check. Scenario 1, they are breathing normally and they do have a pulse.
Okay, good situation relatively. You just monitor them closely, stay with them until the emergency responders take over. Keep checking.
Scenario 2, no normal breathing, but you do feel a definite pulse.
Okay. This points to a primary breathing problem, not necessarily a cardiac arrest yet. So you give rescue breathing, one breath every 5 to 6 seconds for an adult. That's about 10, 12 breaths per minute. And keep checking that pulse every couple of minutes.
Makes sense. Keep the oxygen going in. Final scenario, no normal breathing and definitely no pulse within that 10-second check.
That's it. Cardiac arrest. Begin CPR immediately. Don't hesitate.
And this is where high-quality CPR becomes everything. Let's break down the mechanics.
Absolutely. It starts with compressions. The ratio for an adult is 30 compressions followed by 2 breaths. Always start with compressions.
And the speed needs to be quick.
Very. The rate is 100 to 120 compressions per minute. People mention the song Stayin' Alive. That's about the right tempo. Consistent and fast.
And how hard do you push?
Deep. For an adult, compress the chest at least 2 inches. You need to actually squeeze the heart between the breastbone and the spine to move blood.
I think people worry about hurting someone, breaking ribs.
Ribs can be broken. It happens.
Yeah.
But broken ribs are survivable. Cardiac arrest without effective CPR is not. You have to push hard enough, and just as important as pushing down.
Letting it come back up.
Exactly. Allowing the chest to fully recoil between each compression. If you keep leaning on the chest, the heart can't refill properly with blood, so your next push does almost nothing. Let it spring back fully every single time.
Okay, compressions. 30. Fast, deep, full recoil. Then the 2 breaths, how do we make sure the air gets in?
You need to open the airway. The standard method is the head tilt chin lift maneuver. One hand on the forehead, tilt the head back, lift the chin with the fingers of your other hand. That lifts the tongue off the back of the throat.
But what if you suspect, say, that they fell downstairs or a car crash? Neck injury possibility.
Good point. If you suspect a head, neck, or spinal injury, you avoid the head tilt. You use the jaw thrust maneuver. You place your fingers behind the angles of the lower jaw and lift upwards. It's less intuitive, but safer in potential trauma.
And the breath itself, just a normal breath in.
Just enough air, delivered over about 1 second, to make the chest visibly rise. Don't give these huge, forceful breaths. That risks pushing air into the stomach, gastric inflation, which doesn't help and can cause vomiting. Gentle, just make the chest rise.
All right. 30 compressions, 2 breaths, cycle repeats. Then hopefully someone arrives with the AED, that machine that can fix the rhythm. What's the very first thing you do when it gets there?
Simple. Power on the AED. Find the on button and push it. Don't worry about pads or anything else yet. Turn it on. It will then talk to you, literally guide you through the next steps.
It gives voice prompts.
Yes, clear voice prompts. It'll tell you to attach the pads, where to put them, plug in the connector. Then it'll say something like, analyzing heart rhythm, do not touch the patient.
And that's the critical moment. Everyone backs off.
Absolutely. Stand clear. Shout clear. Make sure nobody, including yourself, is touching the victim. The AED needs an accurate reading, and if it decides to shock, you don't want that electricity going through anyone else.
Okay. It analyzes. If it says shock advised,
It'll charge up, then tell you to push the shock button. Again, reminding everyone to be clear. You push the button, the shock is delivered, and then immediately
jump right back on the chest.
Immediately resume CPR, starting with compressions, for 2 minutes. The AED will typically prompt you after 2 minutes to pause for another analysis. You just follow its lead.
Okay, let's talk about some real-world hiccups. Pad placement. The usual spots are upper right chest, lower left side, like under the armpit area, anterolateral, or one on the front, one on the back, anteroposterior. Key is they can't touch.
Correct. Pads must not touch or overlap. But what if you go to put them on and the person has a really hairy chest? The pads won't stick properly.
Yeah, that seems like a common issue. What's the workaround?
Well, the ideal scenario, if the AED kit comes with it, is a razor. Quickly shave the areas where the pads go. If no razor, and you happen to have 2 sets of pads.
Uh-oh, this sounds painful.
It is, but it works. You apply the first set of pads firmly over the hair, then rip them off quickly. It basically waxes the chest. Then apply the second set of pads to the now less hairy skin.
Yikes. Okay, effective though. What about water? Puddles, sweat, rain?
You definitely don't want to use an AED on someone soaking wet or in standing water. Quickly drag them to a drier spot if possible. Wipe the chest dry quickly with a towel or clothing before applying the pads. Small puddles or just damp ground, even snow, are usually okay, but dry the chest itself. Got it. And implanted devices, like a pacemaker under the skin.
You'll often see a little lump, usually under the collarbone. Don't put the AED pad directly over that lump. Try to place it at least an inch away. Same goes for medicated patches on the skin.
Like a nicotine patch or a pain patch.
Yeah. Peel it off, wear gloves if you can wipe the area clean, then put the AED pad there. You don't want the patch blocking the pad or interfering with the shock.
Okay, that covers a lot of the adult basics.
Yeah.
But things change when it's a kid, right? Especially infants.
They do change, and it's mostly because the reason for the arrest is often different. In children, especially young ones, cardiac arrest is usually secondary to something else, most commonly respiratory failure or shock.
Ah, okay. So unlike adults where it's often a primary heart rhythm problem out of the blue, with kids it's more likely their breathing failed first, which then led to the heart stopping.
Exactly. Their oxygen levels drop critically, and then the heart follows. It's often a cascade effect.
That makes sense why the pediatric chain of survival actually starts differently then. It does. The first link is prevention of arrest. Things like pool safety, preventing choking, treating respiratory issues early, that's paramount for kids. Now, if you do need BLS, generally, if the victim looks like they've hit puberty, you use the adult skills we just talked about. For younger kids and infants, there are adjustments.
Okay, let's take a child, say, between 1-year-old and puberty. What are the key differences in CPR?
The rescue breathing rate is a bit faster, 1 breath every 3 to 5 seconds. And the big change comes with 2 rescuers. If you're alone, it's still 30 compressions to 2 breaths. But if a second rescuer arrives...
You change the ratio.
Yes, immediately switch to 15 compressions to 2 breaths. This provides more frequent ventilation, which is critical since the arrest is likely respiratory in origin.
15.2 for 2 rescuers on a child. Got it. And compression depth, still 2 inches?
The guideline says compress at least 1/3 the depth of the chest. For most children, that works out to be about 2 inches, similar to adults, but 1/3 depth is the key principle.
Okay. Now, infants, under 1-year-old. Big differences there.
Definitely. First, where do you check for a pulse? Not the neck. You check the brachial pulse on the inside of the upper arm, between the elbow and shoulder.
Brachial pulse.
No.
Okay. And compressions. Can't use your whole hand.
No. If you're the only rescuer, you use 2 fingers, index and middle finger placed on the breastbone just below the nipple line. If there are 2 rescuers, the preferred technique is much better. The 2 thumb encircling hands technique. Wrap your hands around the infant's chest and use both thumbs to compress the breastbone. It gives better, more consistent compressions.
And the depth for an infant?
Again, it's at least 1/3 the depth of the chest, which usually translates to about 1.5 inches. So shallower than a child or adult.
Makes sense. What about the AED for kids under 8? Ideally, you want child pads, right? They deliver a lower dose of electricity.
Ideally, yes. Child pads often come with a pediatric dose attenuator cable. You plug those in if available. But what if you only have adult pads?
What do you do? Is it safe?
The guideline is crystal clear. Use the adult pads. A higher shock dose is absolutely better than no shock at all if the AED determines a shock is needed. Don't hesitate because you only have adult pads.
Okay, that's really important. And placement might need adjusting.
Yeah, on a small child or infant, you probably won't be able to fit both adult pads on the front without them touching, so you'll likely need to use the antero-posterior placement.
Oh.
1 pad on the center of the chest, the other on the center of the back.
Got it. Front and back. Let's quickly touch on a specific situation that's tragically common now. Opioid overdoses. The sources mention naloxone. First off, it's not an opioid itself, right?
Correct. Naloxone is an opioid antagonist. It blocks and reverses the effects of opioids like heroin or fentanyl. It's used for overdose rescue. But the BLS approach depends, again, on the victim's state.
Okay, so you find someone unresponsive, maybe you suspect opioids. What's the first thing you assess?
Same as always. Responsiveness, breathing, and pulse. Now, if they are unresponsive and not breathing normally, but they do have a pulse, what's the immediate life threat?
They're not breathing. Lack of oxygen.
Exactly, so you prioritize breathing. Start rescue breathing immediately, 1 breath every 5-6 seconds for an adult. Get oxygen into them first. Then, if naloxone is available and you're trained or protocols allow, you administer it. But breathing comes first if there's a pulse.
So airway and breathing support takes precedence over the drug reversal in that case.
Absolutely, because they're suffocating. However, if you check and they have no pulse, then it's a full cardiac arrest.
Yeah.
What do you do then?
Start CPR. High-quality compressions, breaths, get the AED on them ASAP.
Precisely. Treat it as a standard cardiac arrest. Get the basics done, CPR and defibrillation. Administering naloxone is a secondary consideration in the absence of a pulse. Life support comes first.
Okay, that clarifies the priority. Let's shift gears slightly to when you're not alone, when there's a team. Working together efficiently is key. What's the most critical thing for maintaining good compressions in a team setting?
Preventing fatigue. High-quality CPR is hard work. The guidelines recommend that rescuers performing chest compressions should switch roles approximately every 2 minutes or sooner if fatigue sets in.
Every 2 minutes, that's roughly every 5 cycles of 30.2. Why so often?
Because studies show compression quality, both depth and rate, starts to drop off significantly after just a minute or two, even if the rescuer doesn't feel tired yet. Switching keeps the compressions consistently strong.
Makes sense. And communication within that team, how do you make sure tasks are clear?
Using closed-loop communication. It's simple but effective. If the team leader says, "Can you take over compressions?" the responder confirms, "Okay, I'm taking over compressions." It closes the loop, confirms understanding, and prevents mistakes or missed tasks.
Like reading back an order. What if you're asked to do something you're not comfortable with, say using the bag mask device for ventilation, and you haven't really mastered it?
It's vital to speak up. Tell the team leader, "I'm not very comfortable with the bag mask. Can someone else manage the airway?" It's about patient safety. Better to have someone proficient do it than struggle and be ineffective. Know your limitations.
And what if you see something wrong, like the person doing compressions is slowing down or not letting the chest recoil fully?
You need to provide constructive feedback, clearly and calmly. Say something like, "Try to compress a little faster, aim for 100, 120 per minute," or "Make sure you're letting the chest come all the way back up." It's not criticism. It's about optimizing care for the patient.
Good teamwork is about good communication. Okay, last major area. Choking. Someone is clearly choking, conscious, can't breathe or cough effectively. What's the standard maneuver for an adult or child?
Abdominal thrusts, often called the Heimlich maneuver. Stand behind them, make a fist, place it just above their belly button, grab your fist with your other hand, and give quick upward thrusts into the abdomen.
But what if the person is significantly overweight or pregnant? You can't get your arms around their abdomen effectively.
Right. In those cases, you modify the position. You perform chest thrusts instead. Wrap your arms under their armpits, around their chest, make a fist on the center of the breastbone, and give sharp thrusts straight back.
Same idea, different location. Okay, what if they were choking, you're doing thrusts, and then they collapse, become unresponsive?
You immediately lower them carefully to the ground, shout for help if you haven't already, and then you start CPR, beginning with chest compressions, just like in cardiac arrest.
But there's one key difference when doing CPR on someone who you know choked first.
Yes, a crucial modification. Every single time you stop compressions and open the airway to give breaths, you quickly look into their mouth. See if you can spot the object that was causing the obstruction.
And if you see it?
If you see the object and can easily reach it, try to sweep it out with your finger. If you don't see anything, don't do blind finger sweeps.
Yeah.
You might push it further down. Just attempt the breaths and then go right back to compressions.
Okay, and for an infant under 1 year, who's choking? No abdominal thrusts.
Right.
Correct. It's a different technique. You support the infant face down on your forearm, head lower than the chest, and deliver 5 firm back slaps between the shoulder blades with the heel of your hand.
5 back slaps. Then what?
Then you carefully turn the infant over, face up on your other forearm, again keeping the head low, and give 5 quick chest thrusts in the same spot you do CPR compressions, center of the chest, below the nipple line, using 2 fingers. You alternate sets of 5 back slaps and 5 chest thrusts until the object comes out or the infant becomes unresponsive.
Okay, 5 back slaps, 5 chest thrusts for infants. Got it. Wow, that's a lot of critical information. So let's try to wrap this up. We started by drawing that really sharp line between heart attack, the clot problem, and cardiac arrest, the rhythm problem. That distinction dictates everything that follows.
It really does.
And for that sudden cardiac arrest, especially outside a hospital, the message is clear. Speed matters. Recognize it, call for help, and push hard and fast on the chest. Those compressions are the bridge.
Buying that vital time.
But the actual fix for many of these arrests, the thing that achieves ROSC, return of spontaneous circulation, is that electrical shock, rapid defibrillation with an AED.
That's the definitive intervention for shockable rhythms, absolutely.
Which kind of leads us to a final thought, something for you, our listeners, to chew on.
Yeah, think about this. We know ROSC often depends on getting that AED shock quickly. And we know most cardiac arrests happen at home. So how does the increasing availability or maybe the potential availability of AEDs in more public spaces, maybe even eventually in homes, change the whole dynamic of that chain of survival? Especially when you factor in the complexities we talked about, like needing different pad sizes or techniques for kids versus adults right there in that home setting. How does that shift things?